Sheenam, you want to start?
Yes, sir. Today we have very important topic that is growth modulation for deformity correction, which is used in various kinds of diseases. Will be sorry, there was some network issue. Today we have Maulin Shah sir for the growth modulation topic.
Right. So, thanks, Sheenam. So I heard from Dr. Anil Agrawal that we had a webinar with Dr. Peter Stevens, and he is a current era Bhishma Pitama of growth modulation treatment for various indications in pediatric orthopedics. And I hope this talk will give you a bit of technical aspects of the procedure and the experience which I have gained so far. So we all know that conventional treatment of angular deformity in children needs corrective osteotomies and fixation with implants and plaster immobilization. We know the drawbacks of this surgical procedures, that it needs a major surgical intervention. There is prolonged hospitalization. Plaster immobilization usually is for 4 to 6 weeks, and during this time, children, they are off the school days, and even after plaster removal, they have to undergo tedious rehab, and it takes about a month for them to rejoin the school. So totally, they lose about 2 to 3 months time. And again, the implant removal after a year or so would need major intervention. So because of this drawbacks, the growth modulation treatment came into picture. Growth modulation concept is not new. In 1700s, Phemister started this by destroying the physis on the one side, and so the opposite side would keep on growing. So this was done way back, but due to that, it was used only in patients near skeletal maturity. So growth modulation by definition is utility of remaining growth to correct the deformity. Now, that was a historic way of doing growth modulation, but in current era, there are 3 ways we can do growth modulation. The one and very popular method was staple, putting a staple to induce hemiepiphysiodesis. The screws, percutaneously placed screws, is another way, and the tension bend plates or 8 plate. These are 3 methods. And when we talk about staples, it was started by Blount's in 1949. But staples is a compression device. And when we use a compression device, we always have a fear that it would lead to a permanent closure of the physis underneath. And then we cannot use it in younger children, because if the physis gets sick, then child might develop an opposite deformity. The complications in various papers which has been described by staple is migration of staples or breakage. And the key thing is fulcrum of correction when we put a staple is at the compression site, which is intramedullary. And so correction is slower compared to the implant which is placed on the periosteum or outside the bone. Now, tension band plates or principles, which is popularized by Peter Stevens, and he first published in 2007, is based on the tension bend principle. Small plates in various sizes with 4.5 millimeter fully threaded cancellous screws, which has an angle of 15 degrees. So from each screw, it's spanned by 15 degrees. So one can correct up to 30 degree of deformity. And once this 30 degrees of deformity is corrected, the implant starts backing out to induce further correction. And what is important is it is placed on the outer side of bone over the periosteum. And so the fulcrum is at the periosteal side, and there is a bigger lever arm. So it is theoretically and practically also, it has shown that it induces 30% faster correction than the staple device. When we use staples, the fulcrum of compression is intramedullary, and so we have a shorter lever arm, and shorter lever arm needs more force and more time to correct the deformity. Let me explain to you with a very simple basics. Now, look at this door, and there are 3 hinges on one side, and handle is on this side. So when the handle is away from the hinge, it is very easy to open this door. Now, if I move this fulcrum near the hinge, so for instance, if I move the handle here, you will realize that this will need a lot of force, and the opening of the door will be also slower. So this is the principle of tension band and the fulcrum and lever arm distance. So if you are more away from the hinges or the point of correction, then the correction would be faster. So what we do in growth modulation with tension band plates, for instance, this is a persistent genu varum after nutritional deficiency. And in genu varum, the inner side is growing less faster. So what we need to do is we to put a staple kind of device. We would put a tension band plate on the outer side of femur. So the inner side would keep on growing, and eventually it will correct the mechanical axis. So this is the basic principle or technique of this. And surgical technique is very straightforward. The conventional technique described by Peter Stevens is you put a small or thin guide wire through the physis for a few millimeters percutaneously, and confirm its placement on image intensifier, both on AP and lateral view, and then make an 1 inch of incision spanning above and below the guide wire. And then you go right deep and remove whatever smooth which you can hold with your forceps, and do not injure the periosteum. And once you do that, you guide the plate from the central portion and then put your 2 guide wires. You might pre-drill it, and these 4.5 screws are self-taping. So, so tighten the screws one by one. And now this is the technique video from someone else, but the screws need not to be this long. You know why? I'll tell you in a moment. So this is the conventional method, and once you are well trained to do this, it doesn't take more than 10 minutes to finish this procedure. And compared to the osteotomies and the incisions of osteotomy and rehab, this is fairly straightforward procedure, fairly easy with very less learning curve. And most importantly, it is very child friendly, where we can make them walk on day 1 or day 2. A modified technique has been described recently by Dror Pele, and there's one paper from Argentina which compares the conventional technique described by Peter Stevens and the one with Dror Pele. So what they do here, they do not put any wire into the physis. Sometimes putting a central wire through undulating physis is difficult, but they put a wire into the epiphysis. Then they put the plate over the skin, and they put the second wire. Now, these wires need not to be parallel, they can be a bit of divergent, that is okay. And once they put 2 wires, they remove the plate and they join the incision, joining these 2 wires. And then they guide the plate inside and they fix it. So this incision, this modified technique has a smaller incision and a smaller radiation exposure and so on, but you can do it either way, and this procedure should not take more than 6 to 10 minutes. Now the question is, what should be the length of screws? Now this biomechanical study which has been done, it shows that as this technique works on tension bend principle, it doesn't matter if you put a small screw or a large screw. But screw length should not be too small, because especially in metabolic bone disease, when the bones are weak, there is a subtle possibility that screw would back out. And if your screw is small, it would lose the capacity of providing tension bend principle. That's one. And when the deformities are larger, where you are expecting larger deformity, as I mentioned, once the deformity corrected to the span of plate, then this plate would back out to give more correction. And in that instance, if you are using a very small screw, that screw will back out and it will not serve as a tension band thing. So that's why we need to have not too small screw. At the same time, you don't need too large screw, which I saw in the previous slide. Now, one important point which I learned from Dr. William Cole at Sick Kids, that the length of epiphyseal screw is very important. And whenever you put an epiphyseal wire or screw, always internally rotate the extremity, and so that you can see the femoral condylar ridge. So this is the femoral condylar ridge. Your guide wire or your screw should not proceed beyond this point. The reason is, if you see the axial cut of femoral condyle, the popliteal artery lies in the notch of the femoral condyle. And if by mistake you go a bit too posterior, then you might injure the vessel. And so be careful that your wire should not go beyond this condylar ridge. And that you will be able to see in an internal rotation view of the knee. Let's see an example and how we plan and how we execute this procedure. This 10-year-old girl with genu valgum deformity, bilateral left side is more severely involved than the right, and she is a known case of hypophosphatemic rickets. So you can see the bone quality. So this patient should be simultaneously treated by endocrine team or a pediatrician so that the bone quality is optimum. And her calcium was normal, but phosphorus was 3.2 and alkaline phosphatase was high. In hypophosphatemic rickets, one should not wait for phosphorus to normalize, but one can look at the alkaline phosphatase. If that is near normal range, you can always proceed for the procedure. Now, one need to know three things before considering growth modulation. One is what is the deformity magnitude? So what is the degree of deformity? That's one. What is the location of the deformity? Whether it is arising from distal femur, proximal tibia, proximal femur, distal tibia. So you should be able to quantify from where it is coming. And the third and most important thing is, what is the growth potential of a patient? If the patient's potential of growth is not too good, then the exercise will be futile and will not work. At the same time, physeal health is also important. There are some patients with very sick physis. We see the corrections are very slow. And in some patients with achondroplasia, and they do not correct at all. So one should be also aware about the state of physis. Now, once you need to take full length scanogram with the patella facing forward. This is very important. If your patella is not neutral, then your calculations may go wrong. So you should train your radiologist how to take a full length X-ray. The second thing is, once you have a full length neutral X-ray, you start calculating the deformity by drawing a mechanical axis, which is from the center of the femoral head to the center of ankle joint or the distal tibia. And as we know, when the deformities, the mechanical axis is passing outside the confines of femoral condyle, that is in zone 3, these are pathologic alignment and we need to correct them. The second step is to draw an anatomic axis, or the joint orientation line, which is placed by matching the lines from the distal femoral condyle, most convex part, and proximal tibia was the most concave part of tibial plateau. And then you also draw a line from the articular surface of distal tibia. So these are the joint orientation line. The third step is to draw the mechanical axis of femur, which goes from the center of the femoral head to the center of the femoral condyle. And then comes the mechanical axis of tibia, which is actually the anatomical axis of tibia as well, starting from the center of the proximal tibia to the distal tibia. And then you draw for a genu valgum or genu varum deformities, which are mainly coming from the femur, from the knee joint, you draw the lateral distal femoral angle. And lateral distal femoral angle normally should be 87 degrees. In this case, it is 78 on right and 73 on the left. So about 14 degrees deformity on the left and about 9 degrees from the right. And we also made proximal medial tibial angle. And this proximal medial should be 87 degrees again, which was around 85 in this case. And so the deformity is coming both from femur as well as tibia, but mainly from femur. So my planning would be, I will correct the deformity from the femoral side. So I don't need to put the plate on the tibial side. At the same time, if this child would be near skeletal maturity, I would cheat a bit. I would put the plate on both the sides to achieve correction in short time. How we check the growth potential? So I used to take, and we all try to take an elbow lateral view. And with the presence of olecranon epiphysis, we can assume that how much growth is remaining. So as you can see, when the olecranon epiphysis is like two dots unfused with the rest of the metaphysis, in girls, it matches the chronologic age of 11 years and they have around 2 years growth remaining. And once they reach the point where the olecranon is fused, they have about 6 months of growth remaining from the extremity. But it is a very slow growth. So once the olecranon epiphysis is fused, the growth modulation treatment gives very small correction. So you have to be aware about this. The many colleagues, they see the X-ray of distal femur and proximal tibia, and from the amount of opening which it shows on X-ray, they decide that whether this physis is growing or not. Now that method has some fallacies because some patients also have a bit of procurvatum deformity, and in that case the physis would overlap and it would kind of underestimate the potential of growth. So that's not a very good method. And the second is, some people also use the menstruation age of the child. If the girl is not menstruating yet, she has good degrees of growth remaining. But we see a lot of girls, they keep on growing even after their menstruation age. And some of them, they have pre-puberty, and so that is also misleading. So we have found this elbow X-ray, and in conjunction with other methods, as a good guide of the amount of residual growth. So this is the X-ray of the girl which we're seeing, and it shows that she is at 11.5 and she has good growth remaining. So we did guided growth by placing 8 plates along the medial side of femur, so the lateral side would keep on growing. And as I mentioned, my screw is stopping at the femoral condyle, as you can see on the left side, and this screw size is okay. I would have placed a little bigger screw on the metaphyseal side, but this was my initial cases, one of the initial cases. And in 1.5 years, this deformity got completely corrected and the mechanical axis got neutralized. This is a clinical outcome of that girl from front and from back. So you can correct this deformity this way. And there's a nice paper by Peter Stevens himself in JPO 2006, hypophosphatemic rickets, the role of hemiepiphysiodesis. What we see is these children have diaphyseal and global deformity. So when they're young, you can use growth modulation to neutralize their mechanical axis. And once they become skeletally mature, we use intramedullary nails to correct the diaphyseal deformity. One more child, genu valgum. Now here we measured that this deformity is coming both from distal femur and proximal tibia, and so we placed 8 plate on both the medial proximal tibia and distal femur, and deformity got corrected. So placing the plate is dependent on the origin of the deformity and not the age of the child. Another deformity case, growth modulation in obese adolescents. And there was a paper that you should put multiple 8 plates. And so I used that. And this child, I placed 2 plates in distal femur. And his left side deformity was also coming from tibia. So we placed it and it got corrected, the mechanical axis. And this child also got corrected. Now, there are papers that as this technique is working on tension weight bend principle, you need not put 2 plates, only 1 plate should suffice. Januvarum and growth modulation, this is also, it can be done. Another case of hypophosphatemic rickets with O deformity. So here we have placed 8 plates on the lateral side of femur, and you can see that in about 1.5 years, the deformity got corrected. As you could see, this took a little longer time to correct because the disease patient was not compliant with phosphorus therapy, and so it took longer time. And now, although mechanical axis is corrected, the diaphyseal deformities are still existent, and this child underwent diaphyseal correction at skeletal maturity. You might come across windswept deformity at times, genu varum on one side and genu valgum on the other side. So you choose the proper site based on the X-ray and your calculation. And we placed a 8 plate on the lateral side on the left and the medial side on the right. And this is correction in about 9 months time. So this is how you can correct the deformity. Now, growth modulation can also be used in skeletal dysplasia. Now, this child and his father, they are the known case of metaphyseal chondral dysplasia. The correction is a bit slower in skeletal dysplasia because the physis is sick. But there is a paper recently even in achondroplasia, if you do growth modulation earlier in the course, or as it takes longer time to correct, you have to do correction, put the plates earlier, then you will achieve the correction. So in this case, I corrected both the femurs as well as the proximal femur with a tension band device and correct both the deformities simultaneously. And in a year's time, the child got straighter. Now, few caution you have to exercise while using guided growth method. As I already talked, that do not use extremely short screws, and at the same time, do not use extremely long screws so that you endanger the popliteal vessels. Screw length does not matter while we use tension bend principles. The metabolic disease should be well controlled. In young children, we wait for metabolic disease to be under control before we put implants. And in children near skeletal maturity, we do it simultaneously because we have very less time to correct the deformity. It's very important to have regular follow-up at 3 to 4 months. And parents should be say that when they give consent to this procedure, they are also giving consent for implant removal once we correct the deformity. That you have to explain to them by spending a lot of time with them, because not coming into follow-up periodically, it's a biggest challenge we face in growth modulation treatment. Some people are trying to use reconstruction plates, and occasionally they have shown correction, but there are a lot of complications, screw breakage, probably because it is again, it is working as a compression device rather than tension bend device. So try to avoid reconstruction plates. The question is when to remove the implant. That is very important. We tend to remove the implant once we see a slight overcorrection by 1 station. So why it is so? Because in 30 to 40% patients, we see a rebound of deformity upon removal of implant. Now, there are various opinions about. Dr. Stevens says that you correct with mild overcorrection. Some people say that when it is only 30 to 40% patients are showing rebounds, means 60% they do not show. So correct it when it is neutral. Now, this paper published in JPO 2017, and they are mentioning that 30% patients had more than 10 degrees of rebound. And which patients have more rebound? Younger patients. Well, child, male less than 12 years and female less than 10 years, there are high chance of rebound. And when the initial deformities is more than 20 degrees, they have rebound. So you can plan to remove the implants with a bit of overcorrection in this subset of patients, while in other patients with lesser deformity, you can remove when the mechanical axis is neutralized. And importance of timely follow-up is very important. Let me share this case with you. In 2011, this boy who had a chronic skin disease requiring a long-term steroid therapy presented to us with this sort of X-ray. And our endocrine team treated this child. And in about 1 year's time, his bone quality improved. And then we checked that his deformities are coming from tibia and not femur. And we did growth modulation in the proximal medial tibia. And this was after 5 months. And this is about a year later. You can see that deformity is nicely getting corrected on the right side, but it was not getting corrected as speedily on the left side, probably because the metaphyseal screw on the left side is backing out. I still waited as the child did not have any problem with the impingement or anything. Again, in 2014, a year later, you can see the mechanical axis on the right side corrected well, but now with more correction, the left side screw is backing out more and more. So we revised the plate, and I now place the metaphyseal screw straight, the same screw and same plate. And in 6 months' time, the deformity started correcting. So this case shows that your implant placement should be very precise and not too small screw, especially in metabolic bone disease. So in September 2014, I advised family that you come next month and we will remove the implants. Unfortunately, they had demise of a grandfather in the family. And again, after 3-4 months, one more relative expired. And so they could not come to me, and they came all the way in 2016. Now you can see this deformity has overcorrected. The child who started with genu valgum now has ended up into genu varum. And so what I did, again, we removed the plates from inside and placed on the outside. And fortunately, he had some residual growth and he got corrected in 2018. So in 7 years journey, this child finally got straight, and he is now doing very well. So it is so important to explain to the family that removal of implant in time is very important. Otherwise, they would develop a contralateral deformity. Now, the adolescents near skeletal maturity, they pose a separate problem. They have very limited growth potential. They need actually quick correction of the deformity. And we have seen that when we put this tension band plates or 8 plate, it takes some time before they start inducing correction. This is probably to give some tension on the screws. It takes a few months, and we want to bypass that time. And the PAT screw or percutaneous epiphysiodesis screw, which was devised first used by Junior Matizou in 1950s, as now resurfacing. People are started using this again for deformities near skeletal maturity. And this is the paper recently published in 2016, where they have compared tension band plates with the PAT screw. And they found that PAT gives faster correction. It's useful near skeletal maturity. And they have also found there is less incidence of post-operative pain and stiffness compared to 8 plates. We see some children have stiffness even after a month, and we have to take help of therapists. And rarely we might also need to do manipulation and anesthesia for very stiff cases. So this has not been observed. And the author shows that to keep the screws about 3 to 4 millimeter proud for ease of removal later. So So these are the cases from Dr. Avisha and Mandar Agashe, my friends from Mumbai. For this girl of around 10 years, and she had very limited growth, and they have used the PET screw, and the deformity got fairly fast corrected, and then they removed it. This 13-year-old post-menarchal girl, which have moderate deformity, as you can see, and they use PET screw in both the distal femur and proximal tibia, and deformity partly got corrected, and family is now okay with the cosmesis of this girl. So PET screws can be used near skeletal maturity. PET screw carries a risk that the physis where we put it, it will lead to permanent epiphyseal disease because it's a compression device. But we are not worried in children where they are nearing the skeletal maturity. There are a few more indications where you can use growth modulation. One of them is ankle valgus, which is seen in some children with fibular hemimelia or post-traumatic with a very small bar or myelomeningocele. You can use it, and it has shown ability to correct the ankle valgus deformity. Knee flexion deformity and growth modulation. So especially in cerebral palsy, it is now becoming very popular. And Peter Stevens advocated using two anterior 8 plates. Although they mentioned these are extra-articular, at times it becomes intra-articular and may induce the knee synovitis. Dr. Ashok Johari has some experience with this, and he has warned us to put plates little lateral. Now, another method is becoming more popular, that is extra-articular screw placement with or without patellar tendon plication for crouch gait, wherein we put the screws in the anterior third of femur and from the lateral side. And this is the boy with where we did semitendinosus to adductor magnus transfer at the age of 9 years, and he had rebound deformity at 13 years. So we use this method, and this child shown substantial improvement. You can see his deformities has gone, and he will be around 16 now. So if there is anything residual, we will correct later. But this child improved 1 degree every year, and his 20 degrees knee flexion deformity got corrected in 1.5 years, and he is due for implant removal. Perthes disease, Dr. Benjamin Joseph has always suggested and guided us to do varus derotation osteotomy. At the same time, you do drill epiphysiodesis of GT growth plate. The patients like this, where they have presented to us in advanced disease with intact Shenton's arc, where with an adductor tenotomy and arthrogram, you see the head is very well contained. One of the problem is overgrowth of greater trochanter, and this child was 7 years old, and so we did 8-plate placement along the GT, and you can see the follow-up. This is 2 years follow-up. The disease has very well healed, and the greater trochanter has not shown any overgrowth, and mechanically this child is showing good gait. So one can use in Perthes disease, but when you are doing a varus derotation, you can always do drill epiphysiodesis. And even if you want to do percutaneous drill epiphyseal GT, that is also fairly accepted option. Finally, we tend to use tension band plate for deformities secondary to distal femoral bar formation. So we have used it with bar resection, whether it's traumatic or infective. Let me show you an example. And this paper shows that it is an effective way. So this boy had an infantile infection with the distal femoral bar with exaggerating valgus. As you can see, the growth plate axis and the growth arrest line shows that there is no growth from the medial side. And on MRI, it shows that the bar was about 30%, but as the child was pretty young at 4 years, I thought, let me give a chance to excise this bar and put a tension band plate on the medial side. So this is after surgery. I placed the metal markers to see whether it is working or not. And this is in July 2015. And in 2016, you can see the growth plate is now neutralized. In 16, the deformity got completely corrected and little overcorrected. So I removed the metaphyseal screw, thinking that if I need, again, I'll just put a screw in. You can see the metal marker is progressing further. At a 7 years follow-up, yesterday this child came to my clinic, and you can see the metal marker has grown further. Although this deformity is corrected and the marker is going up, the physis is sick, so this child is short by a few centimeters. This is his final scanogram at 7 years follow-up. His deformity is completely corrected, but he's short and he is now due for limb lengthening procedure. So take-home message is growing children with angular deformities can be treated with growth modulation. As the lecture is too long, I have not discussed the growth modulation used for limb length discrepancy management, which will be dealt with in other sessions of limb length discrepancy measurement later. It's a very simple and gradual correction. The parents should be intellectually sound, or you need to make them intellectually sound about the way this technique works and the need of implant removal in time. And one must be aware about growth potential and the health of physis before considering this treatment. So thank you very much, and I hope this lecture has helped you in your decision making about growth modulation. Thank you.
Thank you, sir. It was a very nice lecture. We have some questions. First question is from Anil sir. How do you use growth modulation for deformities greater than 30 degrees?
Yeah, so there are two subset of patients I have seen. One is the patients with idiopathic genu-valgum or the metabolic disease. There, if the disease is well corrected and child has growth remaining more than 2 years, then we use growth modulation. And then we have seen those deformities getting corrected. So the children with residual growth of more than 2 years, even you can try to correct more than 30 degrees. The other subset of patients with hypophosphatemic rickets, where they have global deformity. So we apply 8-plate fairly early in the course, and then we explain family that diaphyseal deformities would be corrected near skeletal maturity. The third subset is the skeletal dysplasia, like achondroplasia or hypochondroplasia. And there, as the physis is sick, it takes pretty long time. There, my decision is based on intellect of family also. No, some family which are not, we are reluctant or not understanding. So I do acute correction by doing a dome osteotomy in proximal tibias, and might do a bit of hybrid, put an 8-plate on the femoral side and acutely correct the tibia, or vice versa, depending on where the magnitude is coming. So for skeletal dysplasias, I do osteotomies, and for all other patients with residual growth of more than 2 years, I would do growth modulation.
I have put, sir, I have tried putting for the skeletal dysplasia, I have tried putting both in the same distal femur. I do osteotomy as well, but do not overcorrect it and leave the 8-plate in place, so that any residual deformity which comes on later or anything left due to incomplete osteotomy gets corrected by 8-plate gradually. And I use the 8-plate as fixation device for osteotomy. So use a longer plate, plate, bridge the osteotomy site with 8-plate. The osteotomy in these children unites fairly early by 6 weeks. So I give a cast for 6 weeks, and thereafter the 8-plate X.
Okay, that's a fair thing. And we have seen that some of them, although their mechanical axis they are corrected, but because of ligamentous laxity, you know, they still. So keeping an 8-plate is not a bad idea. Recently we did in hypochondroplasia, and I overcorrected by 10 degrees, but still in 6 months time, the deformity recurred and I had to use 8 plates. So yeah, that's a good option.
Second question is, can we use growth modulation in acute rickets?
In acute, sorry?
Acute rickets.
Acute nutritional rickets, because
Okay.
we have, after this corona time, we have a pandemic of these cases,
Yeah.
and everybody comes with deformity. So either to treat them metabolically and wait for 2 years time for them to remodel. And the other option is when they come with a deformity, you treat both metabolically and apply the 8 plate. Have you used them for acute cases?
Yeah, so the acute patients, we term it as a lockdown syndrome, and they have long-standing vitamin D deficiency, and they have also associated proximal myopathy. So they have a lot of pains in the extremity. Now we know that in 3 months therapy of vitamin D and calcium, they all recover in their pain. So if the child has substantial growth remaining, then we make the metabolic disease heal. But the patients who are near adolescent, near puberty, we would treat it simultaneously, and we would not wait for the disease to heal completely, because if we try to wait for 3 months, 6 months, then their residual growth will be limited. So I make sure that if they have around 2 years, see, what we have seen is the degree of correction is 1 degree per year. So if a child has 2 years growth remaining, that is 24 months, or 1 degree per month, sorry. So if deformity is less than 20 or 15 degrees, then you can wait for metabolic disease to heal, and then you can put your plates. But when they are skeletally mature, near maturity, now I started using pad screw, then the 8 plates, because pad screw has shown to give earlier correction beginning than the 8 plates.
So next question is, how do you decide plate size with respect to screws?
Plate size is usually there are 4 plate sizes are available.
Classically 3, sir. Classically 3.
Yeah. So in this universal set or the prototype Pega, even I have done it in Sikis. So they have 4 sizes, 4 different color coding. So you that is for proximal tibia, distal femur, even ankle. So you can put it various places. So what I do is I put the central wire and I put plate, and I make sure that there is enough space for the screw to be placed. Now we all should know that the blood supply of the physis or growth plate comes from the epiphyseal side, and the epiphyseal vessels or E vessels, they lie in very close proximity to the growth plate. So if your epiphyseal screw is very near to the growth plate, then there is a chance that you are damaging the blood supply. So your epiphyseal screw should be little away from the growth plate, and that's the reason why people are advocating putting first the epiphyseal guide wire and then you put the metaphyseal wire, because the blood supply of the growth plate is not from metaphysis, from the epiphyseal side. So I choose the size based on that my screw should be away or at least 5 millimeter from the growth plate.
Yes, sir. So next question is, what's your take on growth modulation in pseudo arthrosis tibia before it fractures?
Now I know that there is a paper showing that doing growth modulation in patients with kind of pseudo arthrosis, they are pre-fractured patients, and they have used growth modulation, and they have shown that growth modulation induces deformity correction. They fail to they do not fracture. But now I have 4 patients of post neurofibromatosis pseudo arthrosis which have not fractured, and I have been observing them. Couple of them have reached skeletal maturity and they have remodeled completely. So that paper has a fallacy that there is no control. So they have not taken in account the patients which were not undergone 8 plate placement. I myself have 3 or 4 cases where I've just splinted them and they have corrected completely. They have remodeled completely. So Vivek, I do not put 8 plates in pre-fractured NFs. Well, I feel that if we protect them well, and if they are not gonna fracture, then they will remodel.
Okay. Thank you, sir. Anyone has any question? Sir, next question is from Sudhanshu, sir. Role of 8 plate in CPMB. CPMB.
What is CPMB? Sorry, Sudhanshu, I'm not good at abbreviations.
Sir, congenital posterior medial bowing.
Ah,
Good morning, sir. Sorry.
Congenital posteromedial bowing. So, I mean, this is well proven that congenital posteromedial bowing patients they correct in their deformities as they grow, and we know that by 7 years both the coronal as well as sagittal deformities correct. Some children have persistent ankle valgus. So when I was young, I used to do osteotomies and growth modulation for ankle valgus in this congenital posteromedial curvature. But I found later in few more of patients that they recover completely. So I don't think we should do growth modulation for those patients who are going to improve naturally, you know. So this is my practice. Dr. Anil Agrawal, do you do growth modulation for this? Now I learned a new term, CPMB.
Sir, I observed them for 7 years.
Yeah.
If they don't correct spontaneously, we still have several years left. The main problem is not of deformity, it is of the shortening of the length. So,
so length be correct.
Yeah, do compensate that, and you can wait for the deformity because most of the things will be clear by 7 years of age. If you require, the growth is also remaining, and you can also do a osteotomy at that time.
So Sudhanshu, I do growth modulation there. See, average discrepancy in cases of congenital posteromedial curvature is about 4 to 4.5 centimeters. And there are some children who have discrepancy less than 3 centimeters. And if parents are tall and long, I would do contralateral proximal tibial guided growth to correct the limb length discrepancy. There I use it. But most of the kids with 4.5 centimeter or more, we do limb lengthening near skeletal maturity. You know?
Next question is, have you used growth modulation in cubitus varus?
No, I have not used it. I have always done osteotomies. Do you have any experience of using it, Dr. Das or Dr. Anil?
Osteotomy only, sir.
I have done osteotomy.
I have done. I have tried 2-3 cases, but I'm not successful.
Have you done growth modulation?
Yes. Tried 2-3 cases.
Oh, okay.
I got a report somewhere and I have tried it, but my experience is also not satisfactory.
So you can share this to us. I mean, I have never done it. You know, so I don't know how it works, because the distal humerus is a slow growing physis. So we have always resorted to osteotomy rather than growth mod. But it will be interesting to see your cases. Yeah.
My question is,
yes.
Any regarding the surgical procedure, any problem you face while doing the tibial to getting this plane? I think sometimes muscles come in between. My experience is, as you cleanly do in lower end of the femur, any problem you face in tibia?
Yeah. So what I have seen is with proximal tibia, we do not see any problem. Even when you put a proximal medial plate for this, we don't see problem. With femur, sometimes we see stiffness. So one thing is, before you close intraoperatively, you flex the knee to the full, And once you flex the knee to the full and then extend, again, look at the IIT, because one time it happened so that when I flexed the knee fully, it was a metabolic bone disease, untreated. So the screws backed out a little bit. So I had to retighten them. But the key is you always flex. So any impinged muscle or any tethered muscle will get separated, you know. So before you go out, you flex the knee to the full. Now, saying that, even after doing this, in some patients, I have seen stiffness. I was talking to other colleagues like Sandeep and some senior colleagues, and they encourage children to drive bicycle and do swimming in post-operative period after 10 days, and that helps reducing their stiffness. I have seen girls; the girls are very they are very slow to resume their normal work. Boys are very active. And in I would say about 20% children or patients, I have required to take help of therapists. And again, physiotherapists work for 2 weeks and their movements are restored. In one patient, we were on the verge of doing manipulation under anesthesia, but that child also improved. I had a word with Taral, and he had one patient where the knee stiffness was such that he required to do manipulation under anesthesia. But that is a problem at times, and some patients have pain, and some patients have persistent synovitis, even though we put the screw a bit more medially. One more complication that Jayant Sampath has reported, and Sheetal has also warned us about, is while you put a medial distal femoral plate, and if you violate the what do you say, that is patellofemoral ligament, then some patients have shown lateral patella dislocation after putting medial distal femoral 8 plate. So those are very rare cases, and we might have done around 200 cases. We have never experienced it, but these are the reports. I had a patient, a girl, where there was a very severe periosteal reaction all across the starting from the distal metaphysis to the proximal diaphysis. Now that girl was from good family. She didn't have scurvy or anything, but what happened is there was bleeding from the proximal screw side, which kept on collecting underneath the periosteum, and that led to a very, very big periosteal reaction, making removal of that implant difficult. So I had one experience, and I can share those x-rays with you all. So yes, we see some random complications with this method, but they are not, they are forgiving complications, and it is always better than doing major osteotomies and plating and implant removal for the conventional treatment.
Many times while doing this bronze type of growth plate, very difficult to locate also the physis in lateral view. If it is fine, but lateral view, the growth plate creates also some technical problems, putting the exactly center of the growth plate.
Yes, yeah, that is right. For that, you know what you can do is, I mostly do it by clinical palpation, and most of the time you feel the condyle and then try to put it in the center. And as there is an undulating physis, so you need to see a dead lateral view of to make sure that you are in the center. So that becomes challenging at times, but either a cross table lateral, and a good IITV technician is needed. And sometimes the figure of 4, you can do figure of 4 and then try to manipulate the image intensifier and make sure that both the condyles are overlapping in the lateral view, and then that is that's a point where you should be in the center. At times it is challenging, but with experience, you know, one can do it very quickly. Right. So I think
Maulin sir, can I say something about stiffness?
Yes, Jaideep. Yeah.
Yeah. Last year we presented our paper in Posicor. So stiffness is more in 8 plate. So as you say previously, the intraoperative finding, we can just sometimes the fellow or other colleague will tighten. So we have to check after putting the 8 plate whether any soft tissue is gone under surface of the 8 plate. That is very important. Second is when we finishing surgery, as you suggest, is knee manipulation. As we see, lot of stiffness present in obese and female child. Those who are a pamper child, we have seen. And literature say it is a daycare procedure, but we have compared pet screw versus 8-plate. There is more stiffness in 8-plate. It will take at least 2 to 3 weeks to get full range of movement. Extension lag at least 4 weeks, and sitting and squatting take more than 1 month.
Yeah.
This is a
That is
conclusion from our
that is
paper.
the right. That's right. But pad screw, using pad screw in younger children, they always carries risk of permanent.
Not I am saying ki younger, just saying the comparison.
No,
The range
I
of
know. Yeah,
movement.
that I agree with you completely. So although this pad screw is looking very attractive, but the one we should confine its use in near skeletal maturity patients, because there are
Yes.
reports of permanent physial arrest in some series after
Yes.
pad screw. So we from pad screw we have moved to tension band, and now from tension band plates to this again to that. So the stiffness, as you rightly pointed out, in obese and a female child from affluent families, we see. So the key thing is to mobilize them when you
Yeah.
are in.
So
when
one
they are in-
paper, you can start from the day one, the physio, whether they have paper from JPO, whether we start physio within 1 week or 3 weeks. So those who have started early physio, specifically some special kit, they will give the good results.
Right. At the same time, I would say that the physio, it was required only in less than 20% kids. So doing therapy for all the kids is also not essential. And some boys, they are so playful. On day 2, they are sitting in cross-leg position in my clinic before they go home. So I don't know, but now I have started explaining to the families of very obese children and the girls, especially, that we might need help of therapists if child fails to bend the knee fully. So I concur with your observations. Thanks for sharing it, Jayant.
Thank you.
I think we should go with this with the complications of 8-plate talk from Dr. Anil Agarwal, senior registrar. Dr. Yeah, please share your screen. I hope you can share your screen. Dr. Ankleshwar.
Good morning, everyone. Is my screen visible to everyone?
Yes.
I'll be I'll be discussing some cases regarding the complications of 8-plate, which we faced in our institute. The first case is a 6-year-old male child. He was a case of multiple epiphyseal dysplasia with spinal deformity at DL junction with bilateral genovalgum, right side more than left side. This was his spinal deformity. We can see a kyphotic deformity at the DL junction. And this was his clinical X-ray, clinical photo showing bilateral genovalgum. And this was his scanogram. We did a bilateral hemiepiphysiodesis of distal femur and proximal tibia using medial 8 plates. And patient lost to follow-up. And after patient presented to us with a deformity of genu varum on bilateral sides, more on the right side compared to the left side. When we ordered a scanogram, we could see there's a screw breakage on the left side. Metaphyseal screw has broken. And this was his scanogram. My questions are, what are the possible reasons according to you, sir, for screw breakage, and what will be the next plan of management?
So yeah, can you go back to previous X-ray? What is this big scar of?
So this is fibula grafting के लिए जो fibula, we use fibula for posterior.
Spine.
Yes, sir.
Acha. For the spine?
Yes, sir.
Okay. May not fibula, but probably tibial sheen graft.
Tibial, sir. It's tibial.
Sorry, sir.
Yeah. Right. So now this is a very well-known phenomenon. Yeah, go ahead in your slides. Yeah, so this is very well-known phenomenon, that is, if the patient is not presenting well in time, it will lead to overcorrection, as in the case I have shown. And mostly two things can happen when the overcorrection starts. As we know that our 8 plates have span of 30 degrees. If it is more than that, either the implant will come out to accommodate more correction, or the screw will break at the head and the shaft junction. So that is what has happened here. And even after breakage, this is not it's acute kind of breakage, it's a gradual stressing of the implant, and it will not lead to pain to the child. So even after breakage, the child has not come, and you can see that screw has migrated up. And on the right side, if you wait for a few more months, it would break on that side as well, because the plate has not come out. Now I can see this, the growth plate is still open. So you can revise it. You can remove these plates and put it on the outer side, and that will correct the deformity. And this time now you inform them the right side is more deformity than the left. So you will need implant removal in 2 separate sessions. You might need to remove implant on left side earlier. Then so he should consent you for 3 surgeries now.
Yes, sir.
But that can be corrected with growth modulation. Yeah.
Sir, do you remove the metaphyseal screw, the broken
No.
part of the screw?
No. You don't need to do that. It will not act as a teether. Don't worry. It is broken and it has gone away. So you don't waste time in removing the metaphyseal screw now. Broken screw.
We removed the implants on the medial aspect, and we left the broken part of the screw on the metaphyseal screw.
Okay.
We did not apply the opposite side, sir. We just waited because growth is still remaining, and we just want to talk about how much does it rebound.
Okay.
Okay. If it doesn't rebound.
So then that the paper of rebound, the rebound is seen only in 30% patients, and in 70% patients there was no rebound. That's one. In 10% patients, even after removal of the 8 plate, there was progression of deformity in the correction mode. So, and in 60%, it remained neutral. So, and in this deformities in your case looks more than 10 degrees. So, even after removal of implant, even if it rebounds, that there will be some residual deformity. So maybe after waiting for some time, you may consider, if it is not coming up, you can consider placing.
Yes, we are planning that. We are planning to observe for 6 months at least.
Yeah.
Ankleshwar, proceed.
Yes, sir. The next case is a 4-year-old child with PFFT, proximal femoral focal deficiency, with a limb length discrepancy of 2.5 centimeter on the right side. This was her clinical picture, and this was her scanogram. We did a medial and lateral hemiepiphyseal of distal femur using 8 plates of contralateral limb to control to correct the limb length discrepancy, and this was follow-up after 8 weeks. We can see a bulge on the medial aspect of the left side. On doing the X-rays, we can see the deformity remained uncorrected after 8 months with metaphyseal screw backing out. So my questions are, what are the possible reasons for the failure according to you, sir, and what will be the next plan of management, sir?
So there was no valgus before the growth modulation, right? It was a straight extremity.
No, sir. The bilateral genu valgum था sir present.
अच्छा, bilateral.
नहीं, genu valgum नहीं था. Ankleshwar इसमें.
But this was limb length discrepancy, sir. Yes, sir.
Limb length discrepancy.
Yeah. So the question is, why the patient developed genu valgum, after doing this, even though we have placed 8 plates on both medial as well as lateral surface. I have not experienced this, but what I feel is the screw placement on the right. Can you go back to the X-ray first?
Yes, sir.
Yeah. So the implant placement is also absolutely all right. There is with growth, there is some backing out of the screw on the medial side.
Yes,
and that probably has not led the physis to stopped growing from that side. So physis has kept on growing, and with the faster growth, the screw has backed out. And once the screw has backed out, it kept on growing. So the patient has developed genu valgum. The plates on the lateral side is working well, and the plate on the medial side is not working that well. That might be the reason. Now, what is the limb lateral view? Yeah. So that is again a good observation, Siddhanshu, that we must make sure that on lateral view, both the plates are in center. And sometimes it happens so that one side plate is a bit more anterior and the screw trajectory is not holding the whole of the physis. Do we have any lateral X-ray, Dr. Anil?
Right now we have not put.
Yeah, so that's a good point, Siddhanshu, and that might be one of the possibilities. So now, you know, the question is, what I would do is, one option is you just remove the lateral plate and reposition the screw on the medial side and let the genu valgum get corrected. And once it gets corrected, you insert the lateral plate again to induce growth modulation for limb length discrepancy. That is one. The other thing is I would take a lateral view and I would reposition the screw, keep that implant, and I would cheat a bit, put a medial proximal tibial 8 plate and let the deformity get corrected from the tibia, because this does not look a very gross deformity. So you will cheat from the tibia and align the mechanical axis, keep the growth modulation and discrepancy management as it is, just change both the metaphyseal screw to a straight construct and put a medial 8 plate. So that's the other option you can do.
Okay, and Kleshwar, proceed.
So we remove the
We took
metaphyseal.
the first option, sir.
Okay, so you did okay, so you place the screw and you remove the metaphyseal. That's fair.
And kept the lateral plate as a sleeper plate.
Yeah, and once it gets straight, you can put the screw through the metaphyseal hole. That is also fine. Yeah.
Yeah.
That's also fine, but it will give some length to the femur. So I hope you have time to, you know, catch up the length. 3.5 centimeter from distal femur means the child should have at least 4 years growth. And I think child seems young, so you will be able to achieve that.
Yes.
Yeah.
Yes. Okay.
Okay. That's good.
My question, Dr. Anil.
Hello.
Hello.
Yes, sir.
My question is whether this screw should be divergent or should be parallel with the growth plate? Any?
Sir, we prefer putting them divergent because that, like in Ilizaro, that takes up the stress and your plate acts early. For parallel screw, I feel that they take some time to divergent and then act. So it's a basically, if you put them in a divergent position, they are pre-tensioned position and they will act more faster than a compared to a parallel plate, although both acts, although both are shown to work.
Suppose you are placing a screw in divergence. So what about only 15 degrees can diverge? From the beginning, if you are correcting the around 7 to 10 degrees, so another 5-10 degree correction is there. After that, it will come out. What is your opinion about that? Because this screw only gives 15 and 30 degrees.
Yes.
So if from the beginning will diverge, so say 7 degree or something like that, or 50%, then only 50%, only 15 degree will be there, or less than will be there. That is just my question to you.
So I agree with your question, Dr. Das. Now, if you read the paper of Peter Stevens, the first paper, and he says that you need not to be absolutely parallel. If it is a bit divergent, then also it is fine. At the same time, they are saying that the one screw divergence gives you 15-degree correction. So if we are aiming at more than 30-degree correction, then it means that you might have to replace your screw again once you achieve optimum correction. So I do not mind if there is mild divergence, because most of the deformities, you know, they are not too much, like it's not in excess of 30 degrees. But in deformities which are bigger to start with, we try to put screws parallel. In this modified technique of Dror-Pele, again, they are emphasizing that you put an transverse epiphyseal wire and then you put a transverse metaphyseal wire, which are parallel to each other. So they are coming up with a parallel screws. So a bit of divergence should not make any difference as long as deformity is not too large. So I think we had a session with Peter Stevens, and if someone of you, if this point is being discussed, that whether the screw should be absolutely parallel or a bit of divergent so that it remains pre-tensed, if some fellow can go through that, Dr. Stevens' discussion.
Sir, he recommended a divergent screw.
Yeah, I read his initial technique video, and he has mentioned 2-3 times we should not mind wires if they are a bit divergent. He can not recommend, but he said that it should be okay if the screws are a bit divergent. Fine. So he recommended, yeah.
Suppose deformity is more, if you convert,
Yeah. So
what is your idea?
Sir, I don't think the 8-plate works by opening the opening of the screw with respect to the 8-plate. It's basically the screw holding the lateral, providing a tether to the physis. And it is not that the deformity will correct only when the screw will open. We have several cases in which the screw remains static, still the deformity corrected. So deformity does not always correct by opening of the or diverging of the screws.
It's a tension band principle rather than the screw. But at the same time, Dr. Anil, we have seen that some patients, once there is enough divergence of screw, the plate starts backing out.
Yes, that's
and
correct.
in your case, you saw the breakage of screw. That's again because the deformity is not the it has gone beyond the span of your screw. So yeah, so that needs some discussion, and maybe we should inquire with Dr. Stevens himself. That's what's his experience. That's a nice point, Dr. Sakti. But I've never placed convergent screws. It is either parallel or little bit divergent, never convergent. Right. Do we have any other case?
Yes, sir. The last case, a 80-year-old child presented to us with bilateral genu varum. This was his clinical picture, and this was his scanogram. Child underwent bilateral hemiepiphysiodesis of distal femur and proximal tibia using lateral 8 plates because of severe changes. So this was his post-op X-ray. And child lost to follow-up due to COVID, and patient presented to us 4 years post the primary surgery. And this was his clinical picture. Child now developed a bilateral valgum deformity. And this was his fresh X-rays and scanograms. My questions are, sir, what is your follow-up protocol? How often do you call the patients for follow-up? And what is the endpoint of plate removal? And how do you decide, sir, when to remove a plate? Is it age dependent, whether child attained a certain age, whether the deformity has corrected itself or not, you have to replace the plate? Or
Glacier, just proceed. We have short time. Just proceed to the next slide. I just wanted to ask a question too. Yes, we removed the plates in this case and applied the opposite side, sir. Just proceed further, Ankleshwar. Yes. The question here is that have you found permanent changes in the epiphysis post application of the 8-plate? Do application of 8 plates deform the epiphysis shape?
So the case which I've shown, the bar excision, where I did bar excision from the lateral side and placed medial 8-plate, although the metal marker is progressing proximal, showing that the femur is progressing, but the physis is sick. So the child has developed discrepancy. So there are certain areas where the physis was already not very healthy. Putting an 8-plate across may make it further sick, so that's the thing. And then we already discussed that the rebound, the loss to follow-up, there are a few papers on it, and they have also found which patients are prone to get overcorrected. One is if the patient is from some other language, they have found that the patient who are not speaking English, in their, and they could not probably understood the importance of timely follow-up. The same practice happens in our center, that the patients from very remote area, that we feel that we have made them understood that they have to come back at every 3 to 4 months and they need to remove implant, but they do not understand the importance of this. So you have, besides communicating with them, now I try to show them the case which I have shown to you. We show them practically on the TV that, see, this can happen. Your deformity will go the other way if you do not come in time. So this is a right observation. If the patient is from some other state, or if they are not understanding your native language, then there is a chance that they would not understand, even though you explain to them, and then you should show some pictorial things for them to understand it better. And second is, very obese children, they do not recognize the correction of deformity unless very late. And sometimes by the time they recognize that deformity is corrected, it is overcorrected. So these two things, the foreign language and very obese children, they are highly likely to have overcorrection. And we must reinforce, just like in clubfoot, every 4 months you have to come. Every 4 months you have to come. I do it for the patients who come from Kolkata or from South. They send me scanograms. They send me pictures if they cannot come. But we make sure that we are in constant touch with them. Yeah, so here we can see that in order to correct the deformity, probably we have created other deformities, but mechanical axis should be well aligned, that's the key. I think it's about 1 hour and 20 minutes.
Yes.
So thanks. Those were very good cases, and I hope best for this cases. Thank you very much, everyone, for your participation.
Thank you, sir.
Yeah, thank you.